All right, welcome. I'm Dawn Ellison, and I'm in the core group of Healthcare Reinvention Collaborative. Our other core members on the call today that I have seen so far are Denise Wiseman, who you know well, and Paul Behrens is here. There's Keely, I see. And I expect Jennifer may join us as well. Welcome to all of you. We're really pleased that you're here. Today's discussion, as you know, is on long-term care. And this is really a critical microcosm of our larger healthcare system. Our panel today brings together passionate advocates who have personally encountered and are working to fix fundamental problems in long-term care. Their insights reveal patterns and challenges that mirror the issues throughout healthcare. So as we examine the forces shaping long-term care, from policy and funding to quality of care, consider how these lessons might apply to your own areas of healthcare advocacy. In line with HRC's mission to identify, connect, support, and illuminate healthcare changemakers, today's conversation will equip you with the insights into both root causes and potential solutions. So just to give you an overview of the format today, we've got a 3-minute video introducing No Country for Old People. Many of you saw the Sizzler last July. That was longer than this. This is an abbreviated form of that. And then I will do a brief introduction of each of our guests, our panelists, and then we will ask them questions directly. So I will ask each of them one question that they will answer. We'll get through all of those, and then we'll open the floor to questions and comments for the guests, from our participants, from our HRC community. So let's go ahead and watch this video, and then I will go ahead and introduce the panel.
Our love is here to stay, not for a year, but ever and a day. The radio and the telephone and the movies that we know may just be passing fancies, and in time may go. Ooh, my dear.
She's coming. Call Edie.
Hi, Mom. It's me, Susie. What happened? What's the matter?
You're hurting her. She's on the tube.
Oh, it's bleeding. So sorry.
I feel impotent to help my mom. She's in pain because they're not taking care of her.
Fighting for his dignity was a horrible battle from hell.
And I'm calling the nurse's station. There's no one picking up the damn phone.
My mother's death was a brutal death at the nursing home.
The nursing home can save as much as $1 million a year by keeping their staffing low.
The lack of staffing.
There's a big problem with understaffing.
Staffing is the root of all evil.
We live in a very ageist society. No one wants to see images of older adults. It doesn't sell.
I love you.
If you're specifically doing it to make sure that the patient just dies in 10 minutes, that's murder.
If being honest and having integrity gets you in trouble, keep doing it.
When cash is the primary reason for doing something anywhere in the healthcare system, people suffer.
There is the huge ethical issue within this industry is you are literally killing people to make more money.
They're trying to make her die faster than she wants to.
Do we care about the patients, the residents, or do we care about the finances of the healthcare industrial complex? And we have to look in the mirror and ask ourselves as a country, what are we going to do for our older adults, for our most vulnerable, for our loved ones? And I think that's why you're doing this documentary.
Thank you. All right. So as you can tell, this is a powerful documentary. And we have Rick and Susie and others to thank for this piece. It's pretty remarkable. And now I want to introduce our uh, guests, and I will introduce all five of them, and then we'll get to an opportunity to really hear from them. So Rick Mountcastle is a retired federal and state prosecutor. He's a producer for the documentary No Country for Old People. He's known for his work as the lead prosecutor against Purdue Pharma, chronicled in the Hulu miniseries Dope Sick. With over 2 decades of experience, he has prosecuted corporations and individuals for exploiting nursing home residents. He led significant cases, including the prosecution of Abbott Laboratories for fraudulently promoting Depakote as a chemical restraint for agitation in nursing home residents with dementia, resulting in $1.5 billion in penalties. Rick believes in educating the public to reform the nursing home system, and the documentary aims to highlight these issues to inspire change. Susie Singer Carter, who you saw in the Sizzler, the mini Sizzler there, is an award-winning filmmaker who has spent the past 3 years focusing on reforming long-term care through her documentary No Country for Old People, after her mother suffered and died as a direct result of egregious nursing home neglect and abuse. She's currently mobilizing the ROAR movement, which stands for Respect, Opportunity, Advocacy, Reform, and working with collaborators, which she affectionately calls her Roariers, to create change in the long-term care system. Patricia Scrapus is a daughter whose mother had a devastating experience in assisted living, leading to her to become an advocate for elder issues and vulnerable adults. She's conducted extensive research on assisted living regulations in Michigan and is working on Teresa's Law to bring more training, transparency, and accountability to the assisted living industry. Melissa Fisher is a senior strategic healthcare communications professional at Kaiser Permanente, who became involved in long-term care advocacy after her father's diagnosis with frontotemporal degeneration and subsequent placement in a facility during the pandemic. She is now working on reform through legislative channels in Oregon, particularly focusing on giving voice to residents and their representatives. Michelle Montserrat Ramos is a state and national patient advocate who oversees the Kathy Olson Patient Empowerment Project at Consumer Watchdog in Los Angeles. She entered advocacy work following the death of her husband-to-be after an elective surgery performed by a substance abusing doctor, and later experienced long-term care challenges while caring for her father with Lewy body dementia. So as you can see, we have quite a lineup here for you today. We're really excited to hear from each of them. So Rick, you're going to start this off. Help us understand the evolution of long-term care in America. How did a system meant to care for our most vulnerable end up prioritizing profit over quality care and have so many workforce challenges?
So that's asking for 60 years of history in 5 minutes or less.
Yes.
I'll do my best. So Medicare and Medicaid were signed into law in 1965. And from the very beginning, the long-term care component was treated as what I'll call a Frankenstein program. Congress didn't want it to be federally funded because of the cost, so it was funneled to the states to be included under their Medicaid programs. Never mind that the federal government provides the states roughly 50% of their Medicaid budgets. But like so many things in healthcare, it was the political illusion that was important, not the reality, okay? So Medicare, the program that was set up to provide healthcare for elderly Americans, really doesn't pay a dime for long-term care. It all gets funneled through Medicaid. Now, adding to the confusion inherent in what's really created this Frankenstein system is that Medicare coverage was set up to provide up to 100 days of post-hospitalization rehabilitation in a skilled nursing facility, the very same facilities that provide long-term care. And this applies to both Medicare recipients who are residents of long-term care facilities, as well as those who do not live in the facilities. And to make things even more confusing, the policymakers thought it was a good idea to allow Medicare to pay significantly more for the rehabilitation that occurs in skilled nursing facilities than Medicaid would pay for this very same patient who is in that facility as a long-term care resident. So the result is a fractured system where Medicare patients or beds, because in the corporate world, they're treated as beds or commodities, Medicare patients or beds are generally more valuable than Medicaid patients or beds in the same facility. And a patient can be both a Medicare and a Medicaid patient, and that patient is viewed as more valuable when they're being paid for by Medicare's rehab funds than they are when they're there as a long-term care patient being paid for by Medicaid. Now, the Nursing Home Reform Act of 1987 established federal standards for care and for the enforcement of those standards in this fractured system. But the surveyors who are responsible for enforcing these standards work for the 50 states. So you have 50 different state-administered inspection and enforcement programs, which are, through the back door, paid for by federal funds. And then now we're at the point today, having fast-forwarded through 50 or 60 years, that 72% of nursing homes are for-profit, that we have this very exponentially increasing demand for nursing home beds as our population continues to age. And according to a 2019 Health and Human Services study, 70% of adults who reach age 65 will need some type of long-term care, services, and support during their lives, which means that the pressure on this Frankenstein system, the pressures are immense and growing exponentially by the day. And the system is not able to prioritize quality of care in the face of a patchwork payment, oversight, and enforcement system. This fractured system is no match for the decades-old business model where owners and operators maximize profit by understaffing and underpaying direct care staff. So where are we today? Owners and operators, of course, seek to maximize profit, but maximizing profit means reducing direct care staff, which means that patient care suffers. Low pay and overwork due to understaffing means that nursing home care workers are fleeing to other better paying and less grueling jobs, like working in retail or even in fast food. And the industry continues to argue that Medicaid reimbursement is too low, it's insufficient. But we can't tell whether that's true or not because related party transactions are not reported, such that according to a 2024 study, up to 63% of nursing home revenue is diverted out as extra profit through secret related party transactions. On top of that, on the enforcement end, inspections have fallen behind due to the pandemic and due to the lack of being able to get people or workers to do the inspections. And enforcement, if any exists, is anemic at best. To top it all off, the nursing home industry spends hundreds of millions of dollars annually for lobbying and campaign contributions to maintain the status quo. They oppose minimum staffing standards and any requirement for financial transparency that might shed light on the adequacy of Medicaid reimbursement and whether excessive amounts are being diverted out through the secret related party transactions. Today, Medicaid pays on average $250 a day for long-term care. How it is that a facility cannot provide adequate care for $90,000 per year is puzzling to me, especially when investment experts tout nursing homes as great investments. However, when viewed alongside a Medicare rehab patient with a Medicare reimbursement rate that is significantly higher, and the ability to double dip after day 20 where Medicaid covers the resident's copay if they're both a Medicare and a Medicare patient, we can see the dilemma for nursing home operators who are under pressure to maximize return on investment. The human cost is systemic neglect and abuse, which is rampant, and a standard of care in our nursing homes that means the loss of dignity, the lack of care, the prevalence of pressure wounds, infections, malnutrition, dehydration, in short, misery. And No Country for Old People is a docuseries that is designed to shine a bright light on this dysfunction. It's designed to educate the public about this Frankenstein system and its impact on our most vulnerable by storytelling that touches the heart. It's intended to educate and activate the public that doesn't know and may not want to know about this broken system. And basically it's intended to encourage people to care. We've partnered with Buffalo 8 as our distribution agent and are looking for a premiere on a premium streamer soon. And along with that premiere, we're looking to partner with advocates across the country to launch a grassroots reform movement that's called ROAR, Respect, Oversight, Advocacy, and Reform. And to that end, we've retained the right to screen No Country for Old People or excerpts from it for educational and advocacy events. We're scheduled to present at the Virginia Governor's Conference on Aging in May. We're working on a screening with the Kansas Advocates for Better Care in the fall, and we'd love to work with your organization or any organization that is interested in advocating for better elder care. And finally, we welcome your support. We're raising funds for music licensing and insurance for our education and advocacy events. So go to nocountryforoldpeople.com to donate. All contributions are tax deductible through our fiscal sponsor, the National Consumer Voice. And also on the website, you'll find a very extensive description of ROAR. We invite you all to join the movement, and we invite you to care. Thank you all.
Thank you, Rick. That's a lot to pack into a little bit of time. I appreciate your efforts. All right, Patricia, you're up next. What are the key barriers preventing reform? You've encountered resistance while working to pass Teresa's law in Michigan. Can you help us understand why making positive change is so difficult?
Yes, thank you, Dawn. First, I want to say I'm really grateful to be here for this opportunity to share my experience and for being included. I'm really honored to be among such an incredible group of advocates. Watching the trailer at the beginning, I'll just have to say, was very hard to see. It was conjured up a lot of memories, and it was a great reminder of why we're all here and why we're doing this. And so, yes, we have experienced a lot of resistance in trying to bring some long overdue changes to the assisted living industry in Michigan. Some expected, some that was not expected. But before I get into that, I wanted to just mention, I think it's important to note that residents and staff that live and work in the assisted living sector in the long-term care continuum are the least protected and supported. There's no federal oversight. And so regulations and safety standards are left up to the states, and some states do a better job than others in ensuring that residents are protected. Michigan has one of the lowest resident safety standards measurements that are really poorly enforced. There's basically no accountability built into their system. We did a state-by-state research and came to the same conclusion of a recent study from the Journal of I have to read this, make sure I get it right, but the Journal of the Post-Acute and Long-Term Care Medical Association ranked Michigan 43 out of 46 states in their 2021 study on stringent assisted living standards, and that covered staff training, admissions and retention policies, medication management, and dementia care. And so when we went into this process, and our mom, had just a really terrible experience that I believe hastened her death, we were surprised on the resistance and pushback because there was so much evidence out there, through aging and long-term care specialists that, there's standards and there's problems. People are getting the care that they need to receive. And then the state has collected some really horrific data on violations at the state level, and I'm sure every state has them, and even at the federal level. So there's a lot of data out there that supports the need for change. And yet, why can't we make the change? And so I believe it's really boils down to two issues, and it's Rick spoke to a lot of this. The first one being the system itself. It is so entangled. This system that is designed to protect seniors and the supports that, make sure that they're getting the services they receive. And I'm in that system, I'm including the regulatory agencies, senior advocacy groups, advisory councils. They are all heavily influenced by the industry lobby. And so we found when we were going through this process and meeting with different groups, different support groups, advocacy groups, legislators, they all had members, providers, and members from the industry on their board of directors. And so they just permeate the whole system. So that's in a high level, the first issue, and I'll talk a little bit more about that, and how their influence really comes through in some of these groups. And the second one, and it was mentioned already too, is that we live in a society that does not value the elderly, that does not value the aged. As a matter of fact, when we went through the complaint process for our mom, during the administrative review, one of the state authority investigators said to us, your mom was old. She probably was dying anyway, as if what happened to her and how she was treated really didn't matter, that she really didn't matter because of her age, that she was old. And so those are two really huge barriers to overcome. But in talking, going back to the system, when we introduced the bill, which was back in 2023, we actually went through a work group process. So the legislation gets introduced, and then they have this work group where they meet with all the stakeholders. And And primarily that is mostly the industry lobby and providers and a few advocates that are in these groups. And what the most striking takeaway I had from that was everybody's primary focus was the health and well-being of the business, as opposed to the health and well-being of the resident. And I expected it from the industry, but I did not expect it from other groups. So that was a real eye-opener for me. But some of the provisions that we are calling for in Teresa's law, I'll just use one as an example, the training. If the business only keeps their business hat on or their financial focus on, they'll see that these things really make good business sense. And so it's ironic that they're opposing them. So one of the pushback that we got on the training that we're requiring, this was from the industry, is one, they said they can't afford, we just can't afford to train the staff. It's too expensive, despite the fact that there are a lot of free training resources out there that we identified for them and that they are aware that they're out there. But there's been a lot of studies by major groups that show the cost of staff turnover ranging anywhere from $6,000 to $8,000 per direct care worker turnover. And so, their arguments really don't wash. And so, we felt that they were just pushing back for the sake of pushing back. I think they're seeing the long-term financial benefit to their business, rather than looking at it from a long-term perspective and seeing training as an investment as opposed to a short-term cost. And so the other reason they gave for training is, and this is something that you will hear all long-term care providers statewide saying, there's a staffing crisis, and so we don't have the time to train the existing staff until we get the staffing crisis straightened out or resolved. And so, yes, we understand that there are a shortage of direct care workers. And so, but our argument for that was, or our push for that is that it's not an excuse to not train existing staff. So you have staff that are performing duties and responsibilities that they're not really equipped for. They're not getting trained. So that's their number one priority. Again, our number one priority is always the resident, their safety, their health, and their dignity. But studies also show that the number one reason that staff is leaving the profession is that they don't feel adequately trained and there's no career path for them, in addition to low pay. And so by opposing this, they're really exacerbating the problem. So a solution that would help abate the situation of the direct care worker burnout and stress and turnover, they're opposing. And so we're really trying to flip the script a little bit and trying to get them to see, businesses to see, that this makes good business sense. It's a win-win for everybody. Not only does it keep residents safe and provide better care, but it also provides the providers with a more stable and competent workforce. And it gives the direct care worker building skills for a career. The more education they get, the more engaged they're going to be with their jobs. So that was the first pushback from the providers or the industry lobby. But the other influence that the lobby had was really on the state regulatory department, the department that is responsible for creating these rules. And in Michigan, they're very lax and vague, and so a lot is left up to interpretation. But one thing that was really striking in this that I want to talk about as an example, and I'll try to do it quickly, but is Michigan is one of the few states that allows unlicensed staff to administer medications without any licensed oversight and with very minimal training. They only require 2 online videos that total less than 25 minutes. And so once a direct care worker views those, they're good to administer medications. And so medication errors happens to be the number one violation for these facilities across all these homes. And our mom had a really bad experience. She was diabetic. And, they told us that they were trained in medication administration. They could handle managing her diabetes, but they were giving her insulin an hour before she ate. And so when she went into hypoglycemia, the staff didn't know what to do. In fact, they didn't do anything, so I do believe that hastened her death. She ended up having a stroke. And so we are trying to bring more training, and we're trying to get the laws on medication, and we're trying to get these laws and rules to reflect reality of what's happening in these facilities. Right now, the rules state that only supervision is allowed in these facilities, meaning that staff can remind residents to maintain their medication schedules or prompt them, to take their medication. But during this work group, what was interesting, all the stakeholders, the state, the lobby, providers, they all acknowledge that most residents cannot administer their own medications. They're just not capable. And so you have a situation where you have this unlicensed staff and you got these residents that are dependent upon them for their health, to be able to understand what it is that they're giving in terms of medication, side effects, that sort of thing. And so when we tried to get these definitions to put forth in the training, the state came back and said, we don't want to change it from supervision only, because leaving it as supervision only, I'm going to read what they wrote, assures compliance, reduces liability, and prevents adverse outcomes. Which I was shocked that was a response. And so, who does it prevent adverse outcomes for? It's the business. It's trying to protect the business. And so in a situation where they are really the main agency that is supposed to protect these residents, their focus is on the business. So those are 2 major hurdles. So the industry has such an influence and such an impact. As a matter of fact, like I mentioned earlier, the Adult Foster Care Advisory Council, which is one type of assisted living in Michigan, that advises the state on regulations, they're primarily all industry lobbyists and owners. And so it's a system that is very hard to break through. When you have every prong, I guess, of the system that is focused on the benefits of the business and the safety of the business, it is hard to break through and have that focus switch to the residents. So those by far, oh, I'm sorry, did I go over time?
No, that's okay. You're almost done, it sounds like. So
Yes, I am. So we're pushing through and trying to make change, but it is going to take, I believe, people with integrity, to have the courage to speak up publicly and to do something to make change, because we've had a lot of people, even within the industry, reach out to us and support us, but they will not do it publicly. So it is going to take a major mind shift to make some change. And so I'm excited to be a part of this group, and I'm excited to see what we can do going forward to make change. Thank you so much.
thanks, Patricia. That's great. So Michelle, with your experience getting bills passed in California, what concrete strategies can you share about effectively engaging legislators on long-term care issues? What motivates them to take action?
Thank you. Thank you for, it's an honor to be a part of this panel, and thank you for all of us for joining us here today. There's a couple things I want to talk about. It's important to engage in our families' long-term care, and advocacy plays a big role in this. We can advocate as a family before placement, during, our family members' time there, and afterwards. There are things that you can do before you consider placing your loved one in long-term care. You need to do your research. Look up who the medical director and the director of nursing is. Go to your medical board website and look up the provider's physician profile. You can find out certain information about them there, including if they have had prior disciplinary actions taken against their license. You can do the same exact action on the nursing board's website as well. Why is this important? When you place your precious family member in a long-term care, you want to know who's in charge of their care, but you don't want to stop there. You can do a Google search and search for the website similar to CalHealth Find. There you will find your state's Department of Public Health records for that long-term care facility. This will take you into a health facilities informational database. Within that database, you can search under the name of the long-term care facility, and it'll list any complaints filed against the facility during the past 4 years, including statement of deficiencies listed, which is a document that verifies that a family's complaint has been substantiated. And it will list errors such as bed sores, medication errors, falls, security issues, etc. It will also include the rare enforcement actions where the facility is fined by the state for violations. These are a few of the steps you can take to conduct some background research on the providers responsible for your family's care, and some background information on the type of problems that occur at the facility, which will give you a little idea of what type of care is provided. Now, if your family member has experienced poor care at a long-term care facility, or is tragically passed away under questionable circumstances, then you can file a complaint with your medical board or nursing board. They all have websites with consumer complaint forms located on those websites. The most important aspect of the consumer complaint is your actual written complaint. You want to identify specific situations where your family member's care fell below the standard of care. Finally, if we want real change in our long-term care facilities, then we need to engage in our healthcare. One way that we do this is through advocacy. The only way that we can make our long-term care facilities in general safer is through policy change and legislation. This is what my team has done. We started our legislative efforts by updating the microcap in California, which is the Medical Injury Compensation Reform Act. The microcap in California remained at $250,000 for 47 years with no change. The cap pertains to pain and suffering, which is a significant aspect of a lawsuit when a senior citizen passes away due to unsafe care. I built our team of advocates during this campaign with families representing just about every segment of the state. I organized informational campaigns in regions of the state where we had multiple losses. Our goal was to update the cap, but it was also to increase transparency and accountability in our long-term system in order to save other families. We met with legislators across the state. As our team grew, we were able to mentor our advocates into community leaders in their districts. Our advocates began to build relationships with their legislators. We attended meetings with them and helped them build their advocacy skills. They began to attend regulatory board meetings with me, where we testified as a unified voice to move issues that were important to the public. We pushed our legislative priorities, which led us to the legislature, where we testified before our legislative committees to help move our bills. We didn't stop there. Most of the work is done in between hearings. I wrote scripts for our team, and we emailed legislative committee members before committee hearings and worked the phones to gain votes to support our bills. We did our research, our outreach from one house to the other until our legislation reached the governor's desk. What ultimately moves legislators are their constituents' stories, our family stories. They have parents and families also. They want to know if the long-term care facilities are safe for their families and their constituents. If you do much of the work for them, their staff, they'll be willing to author legislation to make long-term care in their district safer for their family and others. Within our advocacy, we are starting to see our results pay off for new families. They now have rights that we did not have. More changes are being made, which means more transparency, more accountability, and more lives saved. Thank you.
Thank you, Michelle, and for the work that you've done. Melissa, many people feel powerless to change this broken system, right? What specific actionable steps can individuals take today, whether they're currently dealing with long-term care issues or not? What can we do?
Thank you for having me today. And also, I just wanted to share that my thoughts and opinions are my own, and I'm representing myself here today. Michelle said a lot of what I also agree is we have to get engaged and be passionate activists. And so it's important to remember, though, that any and all advocacy is valuable. We all play a vital role in the care and well-being of residents in long-term care, and influencing change and support takes many forms. Regardless of your relationship to long-term care reform, we're all aging. And whether your advocacy is on behalf of a loved one or for our greater community, or even thinking about your own future needs and wants, there are tangible actions that you can take with whatever time you have to commit to it. The first step in advocacy is caring. And I see here, just even based on this chat, that everyone that's joined this event today has an interest in some capacity to improving the rights of individuals in long-term care. So that's where we start. From there, I think of involvement being 4 levels of participation. Level 1 is begin by paying attention and join or follow organizations that align with issues that matter to you. Not everything starts with a direct experience, albeit mine did. I will, of course, begin by plugging that if you sign up for ROAR and our grassroots advocacy, that is a critical first step, because it's not funded, nor will it ever take funds or from special interest groups or LTCs, because these dollars come with asserting influence. Something I've learned a lot about in the last few weeks about how many dollars go between LTCs to buy the votes and the support of those who are here to protect us. And again, they have an agenda, and they put their business needs first, which equates to control. So ROAR is for the people and always will remain by the people. Support organizations that have a focus on the rights and dignity of those in long-term care. There are many nonprofit organizations that support long-term care initiatives, but be warned, many, if not all the big ones, accept very big contributions from LTCs. I joined a public grassroots group called Caregivers for Compromise 4 years ago to help drive a long-term residents' rights federal bill forward, and I continue to participate. They are not funded by LTC dollars, but they are putting pressure on lawmakers, and we absolutely need your help. I also track the advocacy work of the Consumer Voice, the Alzheimer's Association, AARP, and my own dementia nonprofit, the Association for Frontotemporal Degeneration. They all have an advocacy section on their websites where you can sign up. Being an e-advocate takes 5 minutes tops. They send you links to pre-written letters that you can automatically send to your state or federal legislator. Many have a place for you to personalize it too. And I just learned a little while back about Moving Forward Coalition, which features topics related to long-term care. And they just had a February webinar called Getting Involved in the Age-Friendly Movement. And I believe Denise will share the link in case you want to join future events. Level 2, track legislation and get to know your legislators. This is something that I have been very slow to participate in, but now I am aggressively involved. So every legislative session, there are a list of bills for your state, and at a federal level, bills are being brought before Congress. And you can track them and see who sponsors them. Start by finding your representatives and senators online and sign up to receive their email communications. You can even take it the next step by reaching out to them and letting them know you are a constituent in their district. I find that the emails are very one-sided, but they're also a great way to get better understanding of their position and priorities. And I routinely reach back out and let them know what matters to me and share my personal stories to help drive home why long-term care reform is important. Don't have a story of your own? That's okay too. We should all be looking out for our most vulnerable populations, and that is reason enough. Level 3, participate in state advocacy days every year. And if a bill is coming up that has significant impact on the needs and rights of people in long-term care, see if there's any planned gatherings or marches. Typically, they're held in the first month or two of the legislative session. Advocacy days are events where people gather to meet with lawmakers and discuss important issues. They're also known as lobby days. Typically, there are in person as well as virtual options to meet with your legislators. Many organizations offer training on the issues and talking points for these meetings with lawmakers. As Susie will share with you and has shared, and everyone here has shared, stories are powerful, and long-term care neglect and abuse ones are excruciatingly sad. Our elected officials need to hear them and be moved to act. Turning my pain into purpose is singularly the most powerful thing I have ever taken on. Level 4, serve on a committee, advisory council, or task force. And don't wait for an invite. State, Senate, healthcare, and human services committees have regularly scheduled meetings that are posted publicly and sometimes opportunities where you can sign up to speak on an issue. Related, network. Connect with like-minded advocates across the country and learn and exchange ideas on long-term care issues. That is what I'm working on now. I started to find my people, and we are gathering and strategizing on how we can make our voices stronger together. So basically, for me, it's started something really sad. And right now I'm in this phase of feeling empowered. I also am a little bit fearful because I know that backlash as well as retaliation can happen. And I'm moving cautiously forward because after you've reached that last level that I shared, you are in dark waters. And typically, again, there are people out there who are actually actively looking to suppress our voices. Thank you.
Thank you, Melissa. There's a lot of good things that we can take action in that way. Thanks. Susie, you've noted that statistics alone don't drive change. Stories touch hearts and motivate action. You're a big believer in that. How can we, who aren't filmmakers, effectively use personal stories to transform long-term care from a policy issue into a human imperative?
Right. Well, thank you, Dawn. And I wanted to just give a little bit of my understanding of why stories are so powerful. And Melissa, turning pain into purpose is my mantra. I have lived that since my experience with my mom. And what I know is that, and what I've learned, because so many people have shared their stories with me, is that some people just can't share them openly, and that's okay because they are painful, like you were just saying, Dawn. And and that, that's okay. Everyone can do what they can do. But if you can, stories are powerful. They're so powerful. And I just wanted to talk about the core reason why I've spent the past 3 years working and producing this documentary, because when I went through this journey, I had literally no idea this world that I'd stepped into. I was literally sucker punched, and I couldn't wrap my head around it, but I also couldn't unsee what I saw, and I knew I couldn't compartmentalize this away. So I decided to share my story because I wanted other people to know, to be aware, and to at least be forewarned. And also being a filmmaker, I knew the power of stories that I've told before that have made such a great impact. That one of the things that they do is they humanize issues, because you can hear data all day long and you can listen to reports on the news or a Vice report, and it's data, and data doesn't connect. It just doesn't touch the heart. It doesn't spark empathy, and it really doesn't drive change, because you need people to drive change. And if you can't touch and move people, you're not going to get that change. So the other thing that I found that these stories do is that they amplify voices, personal narratives that have come from residents and family members and caregivers and frontline workers. And that empowers people and validates their experience, and it inspires others to speak out. It gives people that can't or thought they couldn't possibly the courage to share their story. It can shape public perception, because stories challenge stereotypes. We have ableism and ageism in long-term care, and that's one of the narratives that we need to shift. And we can do that. We can do that with story, because we're talking about real narratives, real journeys, and those are powerful. And those stories can also influence, like Don was saying, policy. Policymakers are much more likely to be moved by compelling stories than by facts alone. If you go in with your heart on a platter and let them know exactly what you went through, that's going to be much more powerful than a spreadsheet. They also foster empathy. It breaks down barriers and fosters a sense of community, of humanity, and those kinds of tribes that I call them. That's how you can advocate for change. Those are the powerful tools, or come from your tribes, and that inspires action. And that's why we are creating this movement, Roar, because stories help mobilize other supporters. It takes those stories to create emotional investment. It can turn passive observers into active participants to fight, and in particularly in long-term care, to fight for better care standards. We can also use stories in educating and training. Stories can be powerful tools for caregiving training. They provide context where textbooks don't have that. You can't create that story in a textbook. They also create accountability. When you share stories publicly, institutions are held accountable. And when a systemic failure is exposed by a personal account, it becomes harder for the organization to ignore or dismiss the problem. And I also think it also helps to foster resilience. So when other people hear stories of others who have gone through the same similar challenges, it can provide hope, it can provide validation, it lets you know that you're not alone, and can help provide strategies for coping. And that's so important. I know most of us have experienced, post-traumatic stress going through this because of all the not only the journey that your loved one went through, but the retaliation, the gaslighting, all those things that you're playing whack-a-mole with. It's so much. It's so much to deal with when you have no idea what the system is and how much it's stacked against you. And finally, to leave it on an upbeat note, I think that one of the most powerful things about storytelling is to celebrate our successes, and that positive stories can highlight what is possible, how care can be done right, what models that we can provide for the best practices, and to inspire facilities to strive for excellence. So for us, for my team, in the context of No Country for Old People and the Roar movement, stories are really the heartbeat of our advocacy. They can, like I said, just to sum it back up, they transform abstract issues into urgent, relatable realities, and they drive awareness and, most importantly, action.
Thank you, Susie. Thank you to all of the panel. As you can tell, we really pulled all the punches and brought together some really passionate people. So I really appreciate the work that you're doing and that you're able to be here today to share it with our HRC community, which is a very caring community. And now I want to give them a chance to ask you questions, to ask our panelists about their work, share your own experiences, connect with these initiatives, and explore how you might get involved. What questions do you have from our panel or for our panelists? I know that we've been having some activity in the chat. So who would like to open up their mic and make a comment or ask a question?
Hi, Candace Esham. I know at least half of you on the panel, and very grateful for all the work and hoping to meet more people as a result of this. And thank you for hosting. I'm Candace Esham. I lead a volunteer advocacy group in Delaware. Last year, I successfully led 6 laws being passed into get funding and things like that in Delaware. The funding part is interesting. Definitely you need to keep an eye on things, but I just wanted to share, my LinkedIn is in the chat too, but I definitely agree that the storytelling is very powerful, and there's a balance, between providing the data and research. And similar to Patricia, what was shocking to me is that my grandmother's story of dying didn't move the needle. It didn't matter that they let her foot rot off. Did not matter. So in fact, most of the time when I speak, I don't even talk about my grandmother anymore. I talk about other states' legislation. Where does the funding go? One thing that Rick touched on is all of the federal and state funding that goes through, specifically CMS. There's a form that you can use the FOIA request process. So that's been one of my most powerful tools in getting data that should be transparent but is not. So, happy I share some tips. I actually have a book coming out this spring on my 4-year journey to getting these 6 laws passed. But, it takes a village, and I'm happy that for this community and learning from others, because I know I've learned from Patricia, Rick, and Susie on here, and you have a great panel today. So thank you for doing that.
Thank you, Candace. Helen, it looks like your hand is up.
And Dawn, we actually had an early chat question.
Okay, go for it.
Jason asked, does anyone have any insights into how the current administration will or will not support old people?
Okay, maybe I can answer that. We do not have any guidance at the current time. Let me introduce myself. I know that Rick and Susie know me. I'm Helen Metzger. I actually reside in Northern California, but I'm currently in Portland to participate in research. I am the Long-Term Services and Supports Chair of the NAPA Advisory Council. And for those of you that don't know NAPA, NAPA is the National Alzheimer's Project Act, and the Advisory Council advises Health and Human Services in Congress on Alzheimer's research, care, and services. At the current time, there is still a communications block. I have not heard any guidance or had response to any emails from any of our contacts within HHS or ASPE. Our subcommittees continue to meet. I'll have a chairs meeting on Friday. My subcommittee, and I know research and clinical care within the next week will be meeting. So our work will be ongoing. How it will be received, I have no idea at this point. We have zero guidance. And as Susie and Rick know, this is also very personal to me. I have lost 3 first-degree relatives, my father, sister, and youngest brother, to Lewy body dementia. And so I've got years of experience interacting positively and negatively with the long-term care network. My father suffered severe abuse, 16 deficiencies cited in his care while he was in his final months of journey of life. So I am very pleased to be here. Unfortunately, I am in a ball cap and sweats, so I'm not turning my camera on, but this is important to hear about what is going on in other states. And hopefully I will continue to engage with you and we'll see what we can do. The one other thing that I want to inform about this upcoming year, because we have to put forth recommendations to Health and Human Services. Those have to be filed by July 1st. And my bent this year is going to be long-term care. What we currently do not have at a federal level, there is no definition for memory care. And there has been pushback from the industry for it to be defined, certainly along with other things. But if there is anybody, are there any states out there that have definitions within that have been codified within their state programs? I'd love to hear about it. So, we need to be working together. There is huge amounts of pushback that have been referenced here that I have been warned against. And certainly that is growing day by day. And it is not just growing in long-term care, it is growing in hospice care, palliative care, all other aspects in acute care. The purchasing by real estate investment trust and the purchases by private equity continue to increase daily. So it's got to be a groundswell. Let me go ahead and great. And so what I will do is I will put my email address in the chat. So if anybody has anything to send me, I'd sincerely appreciate it.
Thanks, Helen. Do we have any other hands raised or others? Dan Dow, welcome.
Thank you. And sorry I was late, so I unfortunately missed the first about 30 minutes. But it's assisted living is something, that's been important to me for a while. And, I'm interested for multiple reasons. But having said that, obviously there's a tremendous amount of dysfunction in all the different types of long-term care facilities. And, the perspective that I bring to pretty much everything in healthcare is it's, the ownership and leadership structure and the investment objectives. And so I'm a huge advocate for autonomy through entrepreneurship and ownership. And I support, entrepreneurs that, are trying to, or have programs, that support, clinicians and physicians in their pursuits, both for non-clinical and clinical work. And the reason that I say that, I'm going to place in the chat a link to one of the entrepreneurs I work with. His name is Dennis, and he essentially has a program that can take someone that could be, for example, an employee at McDonald's, and their grandmother goes into one of these, facilities, assisted living facilities, Obviously not a skilled nursing clinic, but just a typical assisted living center, and he can educate them and train them to manage their own facility, help them to find the real estate, launch the business, and then he has a platform that helps them, to actually manage the business. So he can basically take, like I said, an employee that has no idea what they're doing and basically work with them so that they can launch their own business to take care of, their loved ones and others. I mean, personally, I'm much more hopeful and optimistic about solutions like that than, waiting on the government, to fix the system. So I'll put that in the chat, but I just wanted to kind of give that background before I placed it there.
Great. Thank you, Dan. Always a fresh perspective. Looks like Judy's got her hand up.
Yeah,
Welcome,
I would
Judy.
like to just say a couple of things because what you were talking about, Dan, I've done, and I did it out of frustration, just like Susie said, when a loved one is not treated well or is treated really badly and abused. And anyway, and I had no healthcare experience. But over the 7 years, I was with my mom, and she was in these popular memory cares, they said, that had all the new and best, ideas. And it was a nightmare. And I was a barbecued rib salesman for Lloyd's Barbecue regional manager. So I traveled all over the place. And at 55, I gave that up and used what I learned from my mother and about what her needs were and how to get those needs met. And people were not willing to take the time to look at that part of it. And then she was in places where most of them were owned by the big shots. And I went to many financial people in those places and asked them, how the heck do we get you guys to have some compassion before you use your little pen and cross off staff to save some money? And I was at a conference, one of the last conferences I did, and I said, after having built 2 homes, took people from Jerry psych units that were drugged to the hill, took them off all their drugs, made their personalities come back, and then taught my staff how to read the nonverbal language that comes when they're getting ready to get really pissed off. And you can completely stop the behavior. And we did it for 20 years. We have research on it. It works. And my only thing now is I give anything I actually, when I sold it, when I was 75, I got screwed over, but I know it works, and I have all the research that it works. And plus we had, because we taught nonverbal communication to the families, they were able to pick up where they left off. It was amazing. And the families were so, so thankful because they could then at least understand nonverbally what was bothering their loved one. And then you meet that need. And, there's nothing secretive about it once you learn that communication. And we also brought in a barn and 35 miniature farm animals. And by God, when you couldn't get them out of the huff they were in, all you had to do was bring in a miniature donkey or a pig that plays soccer. And you didn't need any drugs. And it worked for 17 years. And I won a Robert Wood Johnson Award because they got pulled into it with a family member that was so impressed. And they came out and did all their thing where they checked with everybody about what you're doing. And we got one of the Community Health Leaders Awards in 2010. And it can be done. And my major frustration is I'm getting too damn old to build it myself. But if I could find, I have all the paperwork and the research and all that stuff is on my website, and people can look through it. I'm in the process of getting for our group to, I have some video that I got probably 15 years ago, traveled around the country talking to family members who had lost their loved ones. They died because of abuse in these places, or no staffing, and someone falls and cracks their head and nobody finds them till the next morning. And it's pretty moving when, Susie, when you talked about stories and things, and it's not about trying to promote somebody's grief, but it does help people see that this is happening, and it's happening way more than anybody knows. And it started getting worse during COVID, and then it's just, now it appears to me, and I'm not an expert, but our model of care worked. We had one staff person to every 3 demented residents. And that's what you had to do. If you wanted them to connect with each resident and know them like the back of your hand and know what their needs were so you could meet them, and then they didn't need an Ativan. So I didn't mean to take over your talk thing, but I do want
Judy,
people to
I'm so
know.
glad that you're connecting with these people. I don't know if you're seeing the chat, but it is lighting up because everybody loves what you've done in those years. And
Well,
this is
and
a
I
great
did it
connection.
for 20 years. It worked. We did research on it. And it was just me when I sold it to some people that took everything away from me. And they shut it down. All they wanted was the money they could get out of it. And the first day after the sale, they fired half the staff. We had 90 staff people taking care of 30 residents. So, you know, I keep telling people all around, because I know that we're all meeting some people. I have no money, but we're all meeting some people that have money. And, you know, I had gone to Netherlands to do some work with their programs over there where they do farms, you know, and that was amazing too. And what I want to be able to do is find somebody with the money to build a couple of, you know, just regular homes on a piece of property. And then I had a whole, well, naturally, almost all of my staff I had with the ranch, and they're younger than I am. So, but they all want to start it again because they said there's nothing out there, and they're so mad because you can't change it. We've tried legislatively. It just gets shot down. Or even if you do get something passed, we worked with a group that we got some staff ratio stuff passed, and Leading Age had all the, in less than a month, they had all the ways around it. And we're out telling everybody about it. And
Judy, you've got your word out to a lot of people today. I think I think something may happen with this. I really appreciate. Yeah, there were 47 people on this call. So
where were they
yeah. So we want to get into our network conversations. Thanks again for everybody joining us today. These, you know, we're all those healthcare change makers, and we aim to understand root causes and find effective leverage points for transformation. Today's discussion of long-term care really illuminates the systemic patterns that can inform change across healthcare. So everybody's insights and questions help strengthen our collective impact. So we're about to jump into network conversations where you'll be giving an opportunity for those one-on-one conversations with someone else on the call. Hopefully you can hang on until 30 minutes after the hour. Before we do that, there are a couple of announcements. If you'd like to connect with any of our guests or anyone else on the call, reach out to on the HRC platform, and we encourage you to take advantage of the growing community that we have there.